Okay. Well, thank you everybody for being here. We've got several people online, so let us make sure that they can hear us and let us know if there's any problem. Very pleased today to introduce Dr. Anusha Vable, who is a social epidemiologist. She's associate professor. This is going to be a little bit, so listen. Associate professor and associate director of the Center for Health Equity in the Department of Family and Community Medicine. And she's the associate director of postdoctoral training at the Philip R. Lee Institute of Health Policy Studies at the University of California, San Francisco. She got her doctoral degree from Harvard School of Public Health and then did a postdoc at the Center for Population Health Sciences at Stanford before joining UCSF, first as a data analyst and then as faculty. Her research agenda focuses on identifying and advocating for structural solutions to health inequities, with a particular focus on educational exposures and healthy aging outcomes. Her research to date suggests that programs and policies increase educational attainment may be powerful mechanisms to reduce socioeconomic and racial health inequities. We're very pleased you're here with us today. She did a great talk when Matt and I were on. Matt and I were battling over who was going to talk with her. And so we're really pleased to see your work today and turn it over to you.
Well, thank you so much for inviting me here to speak today. I'm interested to hear your thoughts on my work. Okay, so all right, so good, thanks. So I just want to start by humanizing myself. I think most people here don't know me. I'm a Midwesterner. I'm from Upper Michigan. I'm a Yooper. For people who know what that is, those are people who are born in the Upper Peninsula of Michigan. So I'm from this little part of Michigan that sticks out into Lake Superior. This is one of my favorite hikes from the UP. I do a lot of hiking. It's one of the ways I maintain my mental health, and I find I come up with most of my best research ideas when I'm walking around outside. I have a young family, so my daughter is 5 and my son is 10 months. This is a picture from us in December, and they are both tiny joys and a very nice distraction from the wider world right now. And something that might not be obvious from my CV is just how often I've failed or been rejected. Before I talk about that, I want to say that I am successful. I'm an associate professor at a soft money institution, which means I have to have multiple grants concurrently, which I do. I have 3 R01 or equivalent grants as PI or MPI. All right, so I'm not going to do an exhaustive list of the times I failed, but these are just the ones that knocked me sideways when it happened. I didn't get into any doctoral programs the first time I applied. I failed a section of the qualifying exam and had to retake it. And I applied twice and never got a K award, which means I entered postdoc purgatory, which I hope is something everyone can avoid. And so I don't tell you this to suggest that my career track is typical, but what is typical is that we're rejected a lot in this career path. I think it takes a lot of gumption, especially these days, to succeed in this career path. And I think that sometimes the stakes are really high, and when you fail, it can be really scary. But I think that even those of us who are quite successful have faced a lot of rejection and should talk to us about it. All right. Okay. So just an overview of my talk today. First, I want to discuss 3 frameworks that really inform my thinking, and you'll kind of see these come up throughout my talk. So first, I'm going to talk about Life Course SES, just briefly about structural racism, and then the seminal social epi paper, Sick Individuals and Sick Populations. Then I'd love to talk about my work on GI Bill eligibility and health equity. Then I'll move to differential returns to educations by sociodemographic subgroup, methods I have known, the potential of one method that I'm really enthusiastic about, sequence analysis, and then just my next projects. Okay, so Life Course, Socioeconomic Status, Structural Racism, and Jeffrey Rose. So I identify and advocate for structural solutions to health inequities with a predominant focus on the education system. There are 3 reasons I like to focus on the education system. One is that it's the most upstream of the adult SES markers, right? Because your job and your education influences your skills, which influence your job. Your job influences your income, and your income influences your ability to accumulate wealth. And so all of these mechanisms might have different implications for health inequities, but education is the most upstream of them, right? There's also additional pathways. Many of us get our healthcare through our jobs, so there's another pathway there. And then also our income can impact where we live, work, and play. So I really think that interventions on education have the potential to influence the course of the rest of your life. So that's one reason I focus on education. A second reason is that it's a primary mechanism for opportunity and upward mobility in this country. We know that from Raj Chetty's work. And then finally, education is unalienable. Unlike a job, which you can lose, or your wages, which can be garnished, once you have education, no one can take it away from you. You have it forever. And so for these reasons, most of my work focuses on educational exposures and educational interventions. Okay, for those who haven't read it, I really strongly recommend this paper by Zinzi Bailey and colleagues that came out in The Lancet in 2017. In this paper, they define structural racism in the abstract. And they say structural racism refers to the totality of ways in which societies foster racial discrimination through mutually reinforcing systems of housing, education, employment, earnings, benefit, credit, media, healthcare, and criminal justice. And the emphasis on mutually reinforcing is mine, not theirs. So this is a graphic from a paper that I'm working on with Catherine Duart, who is a former trainee and incoming faculty at Stanford. And so this graphic is the quotation I read just depicted graphically, right? There's all these different systems like housing, education, et cetera. And then the arrows indicate the interconnections between the systems. So I just want to walk through one of these examples that's especially important for my work, and then Catherine and I have other examples in the paper. So I want to talk about education and housing. So I think we'll start with housing. So I think many people know that there's historical redlining in this country. There's historical racialized discrimination through redlining, which prevented the places where Black folks could live. But there's also contemporary housing discrimination in this country. We have a two-tiered system for housing assistance, and currently more money is allocated for homeowners who are predominantly white than for renters who are predominantly people of color. And so what's really important is that there's an interdependency between these systems, right? In this country, many states use property taxes to fund schools, and that creates an interdependency between your home value and school funding, right? And so the impact of this is really profound. So this interdependency ensures that institutional racism within the housing system produces unequal and racialized opportunities within the education system. Right, so this is just one arrow into education, but in our paper, Catherine and I discuss a couple of the other interactions. And what we're really trying to point out is that structural racism compounds across institutions over an individual's lifetime and propagates across generations to create an unequal and racialized system of opportunity and flourishing. But it's also really important to know that these arrows are choices, and we can make different choices. We can decide to equally and equitably fund our schools and reduce the arrow between housing and education. We can decide that being alive qualifies you for quality health insurance and decrease the arrow between employment and healthcare, right? And that's actually what we must do if we want to dismantle structural racism. All right, the last framework I want to talk about briefly is this paper, Sick Individuals and Sick Populations by Jeffrey Rose. It came out in 1985. If you haven't read it, I really recommend it. It's only 6 pages long, and what he proposes is radical. So in this paper, Rose differentiates between the determinants of the cases, which is the high-risk approach, and the determinants of the incidence, which is the population approach. And so if we're looking about the determinants of the cases, you might ask, why did this patient get this disease at this time? And so typically we look at individual level risk factors such as diet, exercise, and smoking. And the control approach for the high-risk approach is to target those at high risk of disease. So we can contrast that with the population approach. Which asks, why do some populations have higher rates of hypertension while in other populations it's rare? If we want to look at the terms of the incidence, we need to study the characteristics of populations, not of individuals. And the control approach is also really different. For the population strategy, our goal is to reduce the mean level of risk factors in the population. So this is a graphic from Moses' paper where I think that is really that really highlights this approach. So on the x-axis, we have systolic blood pressure from 60 to 200. And then these are just overlaid histograms, right? And so the dashed line is the blood pressure distribution for Kenyan nomads, and the solid line is the blood pressure distribution for London civil servants. And I put an indicator at 130, which is one of the markers for hypertension. And so if we think about how we wanted to control disease for London civil servants, the high-risk approach means that we would target those at high risk of blood pressure. So we wouldn't actually change the distribution. We would just look at this part of the distribution we're fine with, right? It's just once they become high risk, we want to shift them back. We're basically trying to truncate the risk distribution, right? And so we can contrast that to the population approach, where the goal is different. The goal is to shift the whole distribution of disease to one of lower risk. And so you can see how these are like fundamentally different approaches. So in order to test Rosa's hypothesis, you need both a radical structural change that has the possibility of shifting the distribution of disease, and you need a methodological approach that evaluates not just the mean, which is what we typically evaluate, but what's happening across the whole distribution. So I'll show you when we did that in one of our papers that I'll talk to you about in a minute. Okay. So now we'll move on to my empirical work. So a lot of my work is focused on the GI Bill eligibility and health equity. So I have a number of papers on the Korean and Vietnam War GI Bills. I'm just going to tell you what we found for some of the papers, and then I'll dive a little bit more in depth into one that I'm really excited about. And so in this section, I evaluate GI Bill eligibility, not the use of benefits. And this is by design. If we want to evaluate the impact of a policy, we need to study the effect of the policy. And so it makes sense to average across those who are eligible and use the policy versus those who are eligible and don't use the policy, if we want to study the effect of the policy. Okay, so what is the GI Bill and how many people used it? So the GI Bill helps service members readjust to civilian life following military service. It included a generous college education subsidy in addition to other benefits such as home loan benefits and vocational training. And it was really a massive social intervention that reduced college costs for qualifying veterans for up to 71%. And so the Office of Veteran Affairs estimates that about 2.4 million Korean War veterans and 8.2 million Vietnam War veterans used GI Bill benefits. And what I just want to make clear is that the GI Bills were transformational educational policies that really democratized education within the U.S. Before the GI Bills, especially the World War II GI Bills, most of the people who went to college were rich white Protestant men. And so these GI Bills really changed the face of who got higher education in the country. Okay, so these are some mechanisms from the GI Bill to health inequities. So the GI Bill is a benefit for veterans, so you need to have military service to qualify. And so there are two hypothesized mechanisms from military service to later life health outcomes. Here we say later life blood pressure because this graphic is from a paper, but we really think the mechanisms are the same for other health outcomes. So there's one pathway through live combat, and I think unsurprisingly, we assume live combat is bad for health. And then there's another pathway through college education, the GI Bill eligibility in college education, and that can affect both health behaviors and adult socioeconomic status, which can also influence later life health. And so these mechanisms are potentially offsetting, right? So what we hypothesized was that GI Bill eligibility would not be very effective from veterans for higher socioeconomic backgrounds because they could go to college without the bill, whereas veterans from lower and middle socioeconomic backgrounds might disproportionately benefit from the bill, potentially resulting in smaller health inequities. And that is exactly what we found. So we found that GI Bill eligibility was associated with smaller socioeconomic inequities and markers of mental, physical, and cognitive health among veterans compared to non-veterans. So this top paper is my first dissertation paper. I was super excited when I found this. Like I was wanting a policy that I was wanting to evaluate a policy where this might be the case, and I was really excited that we found one that might be the case. So these analyses were associational, not causal. And these analyses, we also looked at the mean. We didn't look across the distribution, right, as hypothesized by Rose. So evaluating changes across the distribution is what we did next. This is our paper. It was led by postdoc Ayush Khadka, who has since moved on to bigger and better things. Our paper was published in the American Journal of Epi last year, and it's entitled Impact of Vietnam-Era GI Bill Eligibility on Later Life Blood Pressure Distribution, Evidence from the Vietnam Draft Lottery Natural Experiment. And so if you want to test Rose's hypothesis, you need a radical structural change, which we thought the Vietnam War GI Bill was, and draft lottery was a radical structural change. And you also need a method that evaluates across the distribution, and we used quantile regression. Okay, so the draft lottery is one of the most credible natural experiments we have, right? Because usually a military service, you can opt into it or there were educational deferments, right? But for a few years during the Vietnam War, military service was randomly determined by a draft lottery that was based on birth date. And so, and while there were still educational deferments during this time, they were less impactful than they were previously because they were much more short term. So this is a causal analysis because there are no arrows into draft lottery eligibility, right? It was randomly assigned, so you can evaluate causality. And so these are our results overall. So first we have our average results, and you can see that GI Bill or the draft lottery eligibility is associated with, it's causal, caused lower blood pressure at the mean, about 1.33 millimeters of mercury, although it does just include the null. And then we look across the blood pressure distribution. So we went from the 99th quantile, this is the null. And so what we found that the quantile regression results showed that draft eligibility lowered systolic blood pressure across the blood pressure distribution with the largest protective effects at the highest quantiles of the blood pressure distribution. And so then what we did was we transformed this results onto the histograms, similar to what Rose did. And so here for the solid line is those who are draft ineligible, and then the dashed line is the counterfactual distribution had the draft ineligible been eligible. And so what we found was that draft eligibility reshaped the blood pressure distribution to one of lower risk by disproportionately pulling the high risk tail towards the center of the distribution. So I also found these results very exciting. But these are the overall results, and we also looked at differences by childhood SES. So I'm on this side this time. So we looked at childhood SES tertile. So we have low, medium, and high childhood SES. And so for the low childhood SES groups, we see that we see similar to what we found overall, right? Slight decrease at the mean, similar across the distribution, slight shifting to the left. For the medium childhood socioeconomic group, actually our results were the strongest, right? So here at the mean, it doesn't include the null. Across the distribution, also largely doesn't include the null. And then when we reshape it, and when we look at the reshaping, it's actually a pretty substantial move towards one of lower risk. And so we can contrast that with what we found for high childhood socioeconomic status, people who are draft eligible but high childhood socioeconomic status, and the results were in the opposite direction, right? Draft eligibility was higher at the mean, higher across the distribution, and shifted the systolic blood pressure distribution to the right. And so if you remember, so what we think is happening here, if you remember before, I said there's two potentially offsetting pathways, right? And so what we think is happening is that for the high childhood SES group, it's the live combat pathway that predominates, whereas for the low and middle childhood SES groups, it's the college education pathway that predominates. that is what we think is going on. All right, so Rose's paper came out in 1985. We believe that we are the first team to test and confirm Rose's hypothesis that a radical structural change can shift the distribution of a disease. So overall, our results on the GI Bill suggest that GI Bill eligibility reduced socioeconomic inequities in markers of mental, physical, and cognitive health, and reshape the blood pressure distribution to one of lower risk, especially for low and middle childhood socioeconomic groups. So that's our work on the GI Bill. I have other work on education that I'd like to share with you next. It's on differential returns to education. So our first paper on differential returns to education came out in 2018, and it's entitled, Do the Health Benefits of Education Vary by Sociodemographic Subgroup, Differential Returns to Education and Implications for Health Inequities. And so when I approached a colleague recently to ask if they wanted to join a differential returns paper, he was like, why would there be differential returns to education? I was like, let me tell you why there might be differential returns. So why is it that socially vulnerable groups may differentially benefit from education than socially advantaged groups? Ross and Mirowski suggest that this could be due to resource substitution, which posits that socially advantaged groups, such as high SES white men, have access to health-promoting alternatives to education, such as power, authority, and earnings that structurally minoritized groups are barred from accessing. This means that structurally minoritized groups are more dependent on the resources to which they have access, such as education, potentially resulting in larger effect sizes for structurally minoritized groups for education than for structurally advantaged groups. So I'm just going to tell you what we found in the first paper. We found evidence of differential returns to education, such that Black women and those from lower socioeconomic backgrounds may benefit more from each year of education than high SES white men, as suggested by the resource substitution hypothesis. And for this analysis, we used the mental health component summary score from the SF-12, which is like not super interpretable. So our question was, do these findings generalize to other outcomes? And then our other question was, is there a better way to operationalize education? In this first paper, we just used a linear term for education. And so that assumes that like an increase in a change in education from 4 years to 5 years is the same as like 14 to 15 years, which might not be a reasonable assumption. So in the next paper, we decided to use a spline for education, where we have a linear term for education up before 12 years, and then a discontinuity at 12 years to represent the high school credential, and then a linear term after 12 years. And we also wanted to use more interpretable health outcomes. So for this paper, we used data from the Health and Retirement Study, and we looked at systolic blood pressure and hypertension. And so this work was led by Dr. Lucia Paca, who's a senior data analyst on my team. So we have our 3 terms for education, each year of education less than 12, the credential, the high school credential, and each year of education after 12, and then the systolic blood pressure will be here, hypertension is here, and then we'll show the results overall and by sociodemographic subgroup. So if we look at each year of education less than 12 years, it's pretty null. There's not much, like each additional year doesn't really seem like it's impacting these outcomes, except for potentially for Black men. It seems like maybe each additional year is associated with lower systolic blood pressure. Then if we look at the high school credential, if we look at 12 years, which should represent the credentialing effect, we again see it's mostly null for systolic blood pressure. For hypertension, however, we see that the high school credential is associated with higher odds of hypertension for Black men. So this is weird and like not the expected gradient that we would expect. Okay. And then if we look at each year of education after 12 years, we see the expected gradient where, it's beneficial overall, and there's some evidence that it's more beneficial for structurally minoritized groups. So sometimes when I present these results, I'm asked, are you saying that we shouldn't educate Black men? No, that is not what I'm saying. What I'm saying is these results should be interrogated to see if they hold in other populations. I showed you the results for blood pressure. We've also found similar results for diabetes. I've seen it pop up enough that I think it might be real for some health outcomes. And so what it suggests to me is that something terrible is happening to Black men as they get more education. And what we think might be happening, but we're not sure, is our hypothesis is that as Black men get more and more education, they move into whiter and whiter spaces to potentially experience more discrimination, resulting in poorer health outcomes. So our differential returns work, we found evidence of larger beneficial associations among women, and Black women in particular, than among men in the relationship between education and mental health. And for Black men, we found additional education may be associated with poorer physical health. And so together, our GI Bill and differential returns results suggest that programs and policies that increase educational attainment could be powerful mechanisms to reduce health inequities. But we still have some questions, do these results generalize to other times and other populations? And so that brings us to the next grant I'm hoping to submit, which is an outcome-wide association study, or OWAS. And so what you do with an OWAS study is you hold the exposure and the confounders constant and you just cycle through all the health outcomes, right? And so this is a way to distinguish the signal from the noise. And because you're doing it for several outcomes at once, you can potentially avoid cherry picking of results. So these results might be more reproducible. And so the aims for our grant. There's supposed to be a box here that disappears. So the aims for the grant is aim 1 is to look at just the OWAS for all health outcomes. Aim 2 is to look for differential returns, either by sociodemographic subgroup, like you saw previously, or across the outcome distribution using quantile regression. And then aim 3 is to establish causality using instruments for education, such as compulsory schooling laws for the 0 to 5 or for the K through 12 period, and then the draft lottery for college education. And so earlier in my career, I focused more on the college education system, but now I focus on education at all levels because not everyone is going to go to college, and the health outcomes of people who don't go to college matter too. And so if we want to move, and so I'm trying to move farther up the educational, farther up education in the life course. And so starting with the 0 to 5 period, we know this time period is critical and we know it's a market failure. If it's a market failure, we need the government to fix this. There's no other option, right? For the K through 12 system, we need to decouple funding of our K through 12 schools from our home values to achieve health equity. And then for college education, states have reduced public funding for higher education for decades, resulting partially in higher tuition costs. I think that college can become affordable again at public institutions if the states decide to prioritize it. All right, so that's an overview of my work on education and health equities. One of the reasons I think I'm able to make these novel substantive findings is that I use unconventional tools. So that brings us to methods I have known. I really think that my strengths at the intersection of equity research and methods. I think often our methods define the questions we ask, which is suboptimal. And so I think what I try to do is I have my question, I find the method that might be the best for answering it. And it's easier when you have a large methodological toolkit to pull from. So these are some of the methods I have used. So the black ones are ones that I've used previously, and then the gray ones are the ones that I'm hoping to move into next. So in the interest of time, I'm just going to I'm not going to go into each of these methods. I'll just show you kind of some of the work we did. So I used matching in my dissertation work, and I was a big fan. I had totally drunk the matching Kool-Aid. I did the simulation analysis. I'm not such a fan anymore. I published what I think is one of the first, if not the first, paper in health literature to validate measures of childhood SES. You actually saw results where we use this. We trichotomized childhood SES in our GI Bill work. I use econometric methods. Again, in our GI Bill work, we used instrumental variables, although those were all in the appendix because we were underpowered. Also, quantile regression. You saw this again in the GI Bill work. And so where we looked at how the draft lottery reshaped the distribution. We spent a lot of time learning this method, and we published this paper to synthesize the literature on it because it's actually like quite hard. I think quantile regression is really important for equity research because most of our methods evaluate what's happening at the mean, but the most structurally minoritized people are most likely in the tails of the distribution. And so we need methods that evaluate what's happening to them specifically. And so one of like the broader themes of my work more recently is that I'm really interested in like using these what I call equity methods, which are methods that are important for equity research, but not taught in typical coursework. And we publish these didactic papers to help people self-learn them. I have recently become an advocate for the more widespread adoption of best reproducibility practices, including code review. In fact, I just gave a talk on code review at the London School of Economics yesterday. It's been a busy week. And so in this paper, we advocate for the normalization of code review. And our paper is entitled, Code Review is a Simple Trick to Enhance Reproducibility, Accelerate Learning, and Improve the Quality of Your Team's Research. And then sometimes you come across a method. Okay, sometimes you come across a method and you realize, oh, this actually solves a problem that comes up a ton. And that happened for me with sequence analysis, a method I've become really enthusiastic about. And so we also recently published this sequence analysis didactic paper in the American Journal of Epi. And so I want to go a little bit more into depth into this method. Okay, so what is sequence analysis? It is not a method to evaluate an exposure-outcome relationship. It's a method to operationalize a variable comprised of ordered events. And so it was first developed to understand DNA sequences in the 70s, and then it came to the social sciences in the 90s. And it can be used as description, or you can use the results as variables in analysis. So what is the problem that sequence analysis solves? So even with just a few states, so you can think about yes, no employment, for people followed over time, so we could think of 18 to 65 years of adulthood, the number of potential sequences is astronomical, even if the number of observed sequences is just a few thousand. But the question remains, like, how can we find similarities across these thousands of unique histories? And then also, what if we're interested in like more complexity? What if we think that if you're unemployed due to disability, that's different than being unemployed due to schooling? Sequence analysis can help us with this. So this is called an index plot. And so on the x-axis, we have age from age 14 to 48. This data is from the National Longitudinal Survey of Youth, 1979 cohort. And then each person is a row on the y-axis, right? And so the orange colors are like the high school trajectories, the blue colors are the college trajectories, and the hot pink is the more than BA trajectories. And so among these about 8,000 people, we found over 3,000 unique trajectories, and using sequence analysis, we could collapse this into 10 clusters of similar trajectories that went from less than high school all the way through grad school. And then so we use these clusters as our exposure in our analysis. Here, this paper came out in 2020. It's entitled, Does Type and Timing of Educational Attainment Influence Physical Health? A Novel Application of Sequence Analysis. And so our research question does the type of educational credential, so you could think about a GED versus high school. You don't need sequence analysis for that question. Does the trajectory to the final credential, so if you get a BA after a GED versus a BA after high school, does the trajectory influence health? And then also, does the timing of attainment influence health? So if you get a BA right after high school or at age 40, do those differentially influence health? And we looked at the physical health component summary score from the SF-12. And so I've ordered these here from less than high school to graduate school, and lower numbers are poorer health. And you see it follows like the expected gradient, where more education is associated with better health. But what we found was that the type of credential matters. So those with a GED, they had poorer health than those within our high school reference group. We also looked at trajectory to the final credential. So we had two trajectories that culminated in the same degree. You could have some college immediately or some college after a GED. And we found if you had some college after a GED, you had poorer health than some college. Similarly, there's two different AA, associate's degrees trajectories. One where you got an associate after high school was associated with poorer health than if you had an associate's immediately. And similarly, we looked at timing of attainment. We found the timing of attainment matters. So we found that those who had got a BA immediately, they had better health than those whose BA trajectory was interrupted. Just want to say that these outcomes were measured at age 50. And so I'm wondering if we look further out, if these might get closer together. So what we found was that the type, trajectory, and timing all matter. And the trajectory and timing were things that we could only identify using sequence analysis. I don't know another approach that lets us figure that out. All right, so there's 3 steps to sequence analysis. There's the data cleaning of the individual level trajectories, the sequence analysis to calculate costs between each trajectory, and then the cluster analysis to group the similar trajectories. And so, as I said, I'm very enthusiastic about this method. So I'm just going to touch on a few applied examples and talk about the untapped potential. So one application that I think is really cool is the analysis of policy databases. And so this work was led by Leah Koenig, who, when she was a doctoral student at UCSF, we had data on state-level abortion policy environments from 1970 to 2013. And so this is our index plot, right? The red colors are states that are more restrictive of abortion, whereas the blue states are more protective of abortion. And so what we see is that in 1973, there was a universal bump towards protectiveness. This is row, right? And then since the 90s, what we see in the index plot is that actually states have been more restricted, have been restricting abortion access since the 90s. And so Leah used sequence and cluster analysis, and she found evidence for kind of 7 trajectories. So she grouped them into the more restrictive clusters, the more moderate clusters, and the more protective clusters. And then she mapped them. And so what we see is that the more restrictive states are kind of in the South and the Midwest, whereas the more protective states tend to be on the coast. And so what we concluded was that even prior to Dobbs, reproductive autonomy in the United States was increasingly curtailed and determined by state of residence. So these results are under review. So they're under review, but we actually have 2 papers where we analyze policy databases that are already out. So in this collaboration with Bryn Austin and colleagues, we looked at state-level cis heterosexism trajectories using sequence analysis and cluster analysis. And then this collaboration with Rita Hamad and colleagues, we used U.S. county policy responses to COVID. You can also, how are we doing on time? Going to finish. Okay, we looked at air pollution trajectories. I think this is another cool example. You can look at healthcare engagement trajectories. I'm sorry, we're just going to keep moving. And so you can look at any life course or ordered event. So we're looking at trajectories of housing instability and trajectories to retirement. There's also this really cool extension called multi-channel sequence analysis, where you can look at 2 channels at once. So we're looking at multimorbidity trajectories and then joint air pollution and poverty trajectories. All right. So my next and submitted grants. So in this current environment, I am pivoting a little bit to focus more on some more clinical applications of sequence analysis. So in February, we submitted this grant with a colleague, Ashley Felix at Ohio State, to look at uterine cancer treatment trajectories. this is one of mine. This where we're looking at memory and functional limitation trajectories using multi-channel sequence analysis. We're looking at urinary tract infection for June, and then the OWASP I previously mentioned for October. But so overall, what I found was that programs and policies that facilitate increased educational attainment may be important mechanisms to reduce population-level racial and socioeconomic health inequities. I also, to answer our research questions, I think we sometimes need to find new tools. And then I think sequence analysis is a flexible method that solves a consistent problem, which is characterizing variables that unfold over time. I just want to close with some acknowledgements. This work wouldn't be possible without my fantastic team. This is from a few years ago, so it's changed a little bit. But I write the grants, but they do the work, and they do a great job, and it wouldn't be possible without them. I also want to acknowledge my mentors, especially Maria Gleamore, who's really been a transformational mentor for me, but also Sanjay Basu, Ashiro Kawachi, Sabu, David Canning, and Marcia Chin. And I also want to acknowledge my funding. Doing this sort of work is much easier when it's funded, and I'm very grateful to my funding, which made this work possible. Thank you for your time. I'm happy to take any questions. A lot, really fast.
Oh, that was a great question.
I can go first. Well,
I thought you might.
it was great to see the pictures to go with the narrative when we talked earlier. I'll start with a question about the differential returns to education, and I guess what struck me is you found some differences that looked like they were benefiting folks who were more disadvantaged, in childhood. And that's sort of despite the fact that many of your other slides acknowledge that the education that many of those kids received is of a lesser quality to begin with because of underfunded schools and underperforming and things like that. So I wonder if have you considered, are there ways to take into account something like educational quality or school performance or something like that into these things? Because it might be that there's more there than what the data show.
Yeah, no, it's a great point. So I have a tiny bit of work on state level differences in educational quality, but I agree that this is an important area that we should move into a little bit more. I think a challenge is the data. We need to get the data on educational quality. We need to decide what level we want it at. Do we want it at the state level? Do we want it at the district level? That seems very challenging to incorporate into analyses. So we do have these state level measures. My mentor, Maria Gleamore, has it. And so I agree that that's something that warrants further investigation.
And this is kind of a piggyback on that. I don't know what data might be available for this, but right now we're seeing, we're beginning to understand what the COVID setback looks like in different districts. And in many places it was dramatic, and in many cases it was, in the better cases, it was sort of neutral or minimal. But I think everybody believes that there are going to be,
there's a cohort effect.
There's going to be a cohort effect that methods like the ones you're using could track. So do you have thoughts about how we might be able to detect that?
Yeah, I need to think about that a little bit more, but I agree that that is like one of the most salient issues of our time. And I think that we have a kind of limited window to do more to really change the trajectory. So yeah, I think that's something that's important to think about.
I thank you for your talk. I had a question about the sequential analysis, sequence analysis. That's a new analytic technique for me. So I was wondering how it addresses confounders. So for example, you found this interesting association between the trajectory if you get an associate's, but you haven't gotten a high school degree, or if you got a BA, but it was interrupted. I assume there's other factors happening that lead someone to not graduate high school or not, or have an interrupted college experience. Does it take into those factors, or that's like the next step that you look at what's going on?
Yeah, no, it's a great question. So this approach is descriptive. So it's not currently able to take into control, to account for time varying confounding that happens during the trajectory. And so the way we're dealing with it right now is that we're looking at, we do two models. We do one where we only adjust for pre-exposure confounders, and then we do our second model where we adjust for during exposure confounders. But there are interesting extensions that I think we're going to look into some more, like multi-channel sequence analysis might be a way to think about like the time varying confounding structure. Another one that Lucia Paca, who's a senior data analyst on my team, has been really into, and I'm like, you need to teach me more about this, but let's talk about it, is this thing called event history analysis, which she thinks might be able to take into account, but I'm not very familiar with it yet.
Did you say event history?
Event history analysis, yeah.
What is that?
I need to learn that from Lucia. Yeah, I'll send her over.
Two questions. One, your work's really interesting and the methods are complex but a lot of policy relevant outcomes from your research. How do you, first question, how do you take these complex methods that would be very hard to explain to a typical policymaker and get them at the right level? Or what do you do with those when you're trying to, get people interested in beefing up the GI Bill or some other policy relevant finding? And then I'll ask the second one.
Yeah, I would love to do that. I don't know, I think it's really important. My work is funded by the taxpayers, and I feel like it just lives in the American Journal of Epidemiology. I don't at my institution, there's no resources or incentives to disseminate. And I think that is really important. And even though UCSF has a really strong connection to Sacramento, it's a medical school and it's mostly healthcare policy that they work on. And so I do training in that. Yeah.
Probably help.
Okay.
Second one, first, thank you for the great seminar. Also for starting with the failure file. Yeah. Because we don't often talk about our failures. Yeah. But tell us, you sort of alluded to this, but what are a few lessons you've learned from the failures?
Yeah. Every time you fail, it's an opportunity to make sure that this is the career path you want to follow. I find sometimes it really knocked me, when I failed the qualifying exam, that was very discouraging. I misread a question and qualifying exam. Anyway, and so, I think that, like I said, you just need to have a lot of gumption. And I think that, after my K wasn't funded the second time, I had multiple mentors being I don't know if this is going to work for you. Are you sure that academia is the right path for you? And I was I can't consider, I'm not going into industry. And so I was no, this is what I want to do. I need to try harder. I need to try again. And then I got a lot of grants funded in 2019. Or no, I got a grant funded in 2019, and it was the American Heart Association one, the Career Development Award, and it was really transformational for me. But I think it can be really hard. And the other thing that happened for me is that so my K was never funded by the American Heart Association or by NHLBI. It scored a 44. But when I sent it to the American Heart Association, same exact grant, it was scored in the top percentile. And so that was a really important lesson for me that even though my research might not be supported by NIH, it doesn't mean it's not impactful. It doesn't mean that there's other people who might not support it. And then also with my K, I took the first 2 aims and turned it into my first R01, which was then funded. So I just switched the outcome. And so I think that I think that sometimes you just especially in this current environment, I've been telling my team, we need to be even more bold and even more strategic. And sometimes the strategy is switching the outcome, if that's a possibility, applying to other places, focusing on different methods. I think it can be a challenge.
Did I interrupt somebody?
No.
Okay. It's related. We talked a little bit about it this morning, and I think especially now, in this kind of changing environment, you talked about you have had some great mentors.
Yes, I've had some transformational mentors.
And what made them transformational?
So like with Maria Gleamore has been transformational for me. And so, I mean, I feel like she took me under her wing when I was a doctoral student, and she was like, I feel like both Maria and Marshall, they believed in me before I was able to believe in myself. And I think that really helped me. And then they also showed me kind of like when I didn't get into any doctoral programs, I was at the University of Chicago. I was working with Marshall Chin, and he was like, you got to keep going. Like you're going to hit setbacks, but you got to keep going. And so I think that those kind of things really help me. But I think that really when they see you and they know your strengths, and they know your strengths even before you know them yourself, I think that's really.
And especially in this environment too, where
Yeah. Mm-hmm.
Any other questions? Well, thank you. That was really great. I'm going to do the sequence.